Wonderful. Well, thank you all so much for taking the time to spend an hour during what I imagine to be a busy clinical or work day for you, wherever you're sitting in the state today. I'm grateful for your time and hope that we are able to use this hour for the betterment of the people we get to serve. I do want to just address a couple of things before we get started. First, let's see if this will toggle. No, let's see. Okay, the first, I have no conflicts of interest to disclose. I do, however, want to disclose that the work that I present today is in no way my work. It is the work of a big group of team, many of whom I will try to explicitly name today because the work is the work that they are giving to this world. But I am simply one person presenting for a much larger team of people without whom we could not do what has been done to date. The second thing I want to kind of frame as we begin today is the importance of the patient voice. If I had done my job better today, I would have asked Rachel for permission to perhaps have a patient, a person living with substance use disorder during pregnancy, who was interested in and willing to share her story. It is a really important part of our understanding of speaking about substance use disorder is framing it in the context of people with lived experience. And in the absence of having a separate person today, I would just ask your permission to read a brief part of a story from a patient who has been with us in our clinic several times over a few pregnancies. And her story is both harrowing to me to read and also not unique at all. And I think it's really important to have these voices frame the work that we do together clinically and in social workspaces. So with your permission, here is a brief, direct verbatim testimony from someone. My mom was the first person to hand me my first joint at 9 years old, but harder drugs at the age of 10, of which Lortab and a Xanax were one. My mom wanted somebody to get high with instead of being a mother. Unfortunately, I fell for it. I was on pills from 2000 until 2021. Of course, there were other drugs in between, crack, meth, coke. Basically, whatever there was, I did it, except heroin. In August 2021, I actually got on Suboxone on the street because I didn't know you could just walk into a clinic. I was terrified of getting something that had fentanyl in it. When I got pregnant with my daughter and I got into the Magdalene clinic, they got me on the Suboxone legally, and I've been sober since. With the support of my kids, my sisters, both of my best friends for over 20 years are sober too. And then I also have the support of my peer support team, my SA prep, sexual assault prep, and my trauma counselors that I adore very much. But bigger than anything, the person that helped me the most, besides my kids, would be Susan Brown. I'm going to pause for a second. Susan Brown is an extraordinary nurse practitioner who works in the Magdalene Clinic and provides exceptional care. She helped me pull out trauma that I haven't spoken about since elementary school and middle school, which was a few of the main things I was suppressing with the drugs. I can proudly say that I haven't had no cravings or setbacks since arriving at the Magdalene Clinic. And again, this is a person for whom we've had the privilege of taking care. We are now in her third pregnancy. So that is the story. And I want to frame this today with a patient presentation. This is a generic, non-specific patient presentation, but is absolutely the most common thing that we see. So DK is a 24-year-old gravida 2 para 0. She's 21 weeks gestational age by LMP alone, who presents for an initial prenatal visit and IPV. Her past medical history is significant for moderate opioid use disorder, not in remission. We'll talk a little bit later about how we code OUD and how we get the diagnosis of moderate. Also, depression and tobacco use disorder. Her social history is significant for being single, unemployed, with unstable housing. So if this patient is familiar to you, and she probably is if you're providing obstetric care in South Carolina, she is also familiar to the Department of Public Health and to our statistical reporting partners. So this will likely be very familiar to every one of you on the call today. This is the South Carolina Maternal Morbidity and Mortality Review Committee's, excuse me, legislative brief. This is the 2025 brief, which presents data from 2018 through 2021 and is looking at specifically pregnancy-related mortality rates. The graph on the right of your screen will demonstrate year-over-year changes in pregnancy-related mortality rates for the entire state, and those are normalized per 100,000 live births by convention. The gray line in the middle is the total state rate, and then variations in that rate year over year are seen for populations identified as non-Hispanic Black in green and non-Hispanic White in blue. When we normalize data for rates by number of live births, 100,000 live births, it can be tricky to quantify exactly how many deaths within 12 months of pregnancy we're speaking of. And for 2021, that number was 27. When you dig into the data and look at the causes, the leading causes and circumstances surrounding pregnancy-related deaths, several trends come up. So first, in 2024 legislative brief, mental health conditions, and specifically substance use disorder, was the single most common cause of pregnancy-related death. When they added in the 2021 data for the 2025 brief, what we see is infection exceeding mental health conditions. That infection was defined largely 13.8% of those deaths by COVID infections. And so if you exclude COVID infections, mental health conditions and substance use disorder related mortality was the single largest driver of death and really preventable death in South Carolina. Similarly, they look at circumstances of pregnancy-related death, so not necessarily the cause, but other things in that space. And what they found is that substance use disorder complicated 23% of pregnancy-related deaths from 18 to 21. I share frequently with folks, my father-in-law will be 85 in November. He is an OBGYN who practiced for the longest time in Greenwood County. And if you ask him what kills pregnant people, he will tell you it's hemorrhage, hypertension, and infection. And those, of course, were the classic causes of mortality in this space. But that is no longer the same truth for us, particularly in the deep American South. I pulled the similar data for North Carolina, our sister state, and looked at leading causes of death in North Carolina. North Carolina has a significantly higher number of deliveries per year, but a very similar patient population. From 2018 to 2019, which is the most recently reported data I could find in their 2024 report from DHHS, they had 24 mental health deaths over those years. You see on the figure 2 in your upper right-hand corner, overwhelmingly the most common cause of death. And of those mental health deaths, which is certainly an umbrella term, when you dig into the data, 20 of the 24 were overdose related. 18 of those overdoses were opioid related, and very specifically, 14 of those deaths were fentanyl specifically. So fentanyl alone killed more people in North Carolina than postpartum hemorrhage, hypertension, and infection combined. Those are very important data for those of us that take care of pregnant people every day. So patient decay is very similar to patients we see all the time, and also similar to the patients who have a phenotype suggestive of a high risk of mortality in the postpartum period. These data also come from, well, they came from DHEC, now we'll call them DPH, and these data are not specific to pregnancy. So these are South Carolina specific deaths from overdose, and they tell a really compelling story to me. The blue line is the number of overdose related deaths that were deemed intentional. So these are suicides, and that number from 2012 to 21 has remained essentially unchanged. What has remained dramatically, or what has become dramatically changed over time from 2012 to 2021 is the rate of unintentional overdose related deaths. You see a relatively steady slope from 2012 to 19, and then a very sharp inflection point in 2019 through 2021 that has continued, and that's largely attributable to fentanyl. So total deaths mirror unintentional deaths because it is overwhelmingly the most common. So again, just to put this in scale, in South Carolina, so in 2021, that year we had 2,168 neighbors who died overdose-related deaths. That same year, we would have had 416 infant deaths, so deaths within the first year of life to a newborn, and 18 maternal deaths. I share this not to soft pedal the significance of maternal deaths in our state. It is a massive problem, but to tell you the scale and scope of overdose-related deaths really is pretty extraordinary, and we cannot, in the healthcare field, be sleeping on these data. So this gets me to one of my primary points, which is that substance use disorder, and particularly today I'll talk about opioid use disorder, may not be a disorder that we created in our field, but for better or worse, we are very likely the people best positioned to reduce suffering related to it for our pregnant people in South Carolina. So it gets to this question of what is best practice for this disorder, and really what the Society for Maternal Fetal Medicine, ACOG, and ASAM, the American Society of Addiction Medicine, all recommend best practice for pregnant folks who have substance use disorder is a one-stop shop model. That's what we should really be striving for. And what is that? It is a coordinated multidisciplinary care program that includes the following four critical pieces. The first is they have access to medications for opioid use disorder. The second is they have access to behavioral health. The third is they can get their prenatal care there. And the fourth is they get social support. So these four things all need to be linked together for kind of best practice. And the ideal setting, of course, is that it's all co-located, and that is not hard for us to imagine. I took my kiddo to a doctor on Monday night, and what a gift if the lab is in the office with the pharmacy. If everything is located together, such a gift. Every time you have to leave a door and enter someplace else, that's an extraordinary burden. So this is the story of the Magdalene Clinic. The Magdalene Clinic was started 1 year before that inflection point in 2019. So we started really in earnest in early 2018, and it was designed to be that one-stop shop for people. It was designed very humbly by a team of 3 people with very limited expertise in substance use disorder. I feel comfortable saying that because I was that clinician who had no specific training in that, but who reached out to our local addiction medicine clinic and asked for a partner to come do the care with us. And it was really the gift of the Phoenix Center being creative and generous in their sharing of resources, putting a peer support person and ultimately a peer support person and a licensed professional counselor there in the clinic, the prenatal clinic, with us to try to provide this care. Over the years, Magdalene has grown by leaps and bounds. What started as a single physician, myself, a nurse, and a peer support person has grown now to be a nurse practitioner-led model. Seen on the screen are Susan Brown, the testimony about whom I read earlier, and Brandy Pearson, both of whom have provided exceptional care for years. You see Amber Goforth, one of our peer support specialists, Minnie, one of our nurses. And then on the right of the screen, you see what I love, which is a satellite clinic. So a group of family medicine physicians said, we think we can do this too, and set up a rural version of this clinic in Seneca, South Carolina. So there is replication possibility for sure with Magdalene. A critical piece of understanding for all of us that do this care is that the care model puts the patient at the heart of each visit and affirms that substance use disorder is chronic and treatable. It is no different than diabetes in that way. It is not a moral failing. It is a treatable medical condition, and we have not done a great job of understanding that over the years. So what exactly is Magdalene? And this is a little bit of an older graphic, but I'm not very gifted in graphic design, so it's the one I have to present to you today. So Magdalene is that one-stop shop. It is co-located services for folks. So a patient comes in, and what can she get? The first is we have amazing nurses. They're the face of our program. Their job is to be a very warm welcome, to do multiple different social screeners, to make sure our patients have what they need when they come in the clinic. We have trimester-specific gifts that our patients gift. All of that, our nurses are really the face of the program. We have addiction medicine partners. We have a peer support specialist who's been with the clinic for years. She is at the elbow and does care and coordination there on site with us when we're doing the Magdalene Clinic. We no longer have a licensed professional counselor. She has gone on to another wonderful role, but would love to fill that role. We also have expedited referrals for medications for opioid use disorder. We refer to the Phoenix Center and Addiction Medicine Center frequently with same-day access to buprenorphine for patients who want to start that. We also have a very expedited referral pathway for intensive outpatient therapy or inpatient care. Our facility in the upstate is called Serenity Place. It's a 16-bed unit that deserves its own conversation. The work they're doing is missional and highly evidence-based, and they partner with us. There's a beautiful back and forth between Magdalene and Serenity Place. We also have really great prenatal care. I've mentioned a couple of the nurse practitioners who lead the model for us. And then, of course, our social workers, case management, referrals, screening, and advocacy. Other things that happen that I didn't mention already, our peer support specialist gives harm reduction bags to all of our patients who are willing to accept them. Those have the traditional condoms, clean water, fentanyl testing strips for folks who are still in active disease, and Narcan in every bag. We also have an expedited referral program for folks into the Managing Abstinence in Newborns program, Dr. Jenny Hudson's program, that will take care of the infant after birth if they're opioid exposed. And then we have expedited referrals into a perinatal psychiatry program led by Dr. Neha Hudapol and her team. I have this piece there about medical legal partnership, which there is a vibrant MLP program in the upstate for civil law issues. I will say we have actually not had a tremendous amount of success in that space. So many of our patients who have legal issues are actually dealing more with criminal law issues, and MLP is not able to handle those, but it would be available to them for basic civil law issues, which is great. And then what have we done in Magdalene over the years? So to date, we have taken care of 614 unique patients, and that represents 835 pregnancies. So doing the math, many of our patients have come back with a second pregnancy. The story I read earlier is in her third pregnancy with us. Our average patient is 28.7 years old. She's a G3P2, publicly insured, and a current smoker. SUD diagnoses over the years for those 835 pregnancies, the vast majority, 84%, are polysubstance use disorders, with single disorders represented opioid use disorder more than half of our patients. Stimulant use disorder was actually the number one diagnosis in our earliest days, but now opioid use disorder has surpassed that. Cannabis use disorder is seen in about 38% of our patients, and about 17%, not a small percent, have been coded as current or previous alcohol use disorders. Let's see. Maternal outcomes, our vaginal delivery rate is a little bit lower than we'd like to see, but not totally off the state average, 63.9% vaginal delivery rate. Our postpartum visit attendance rate is a little bit lower than the parent clinic in which the Magdalene Clinic sits, and is certainly an opportunity for improvement there. Our median Edinburgh postnatal depression scale score is a 6 with an interquartile range of 2 to 11. And then really important for us has been looking at what happens to our patients within that first year of delivery. And being a large health system, we're able to survey ED visit utilization. More than half of our patients will not be seen in the emergency department within a year, which is great. But the flip side of that is a significant portion will. 25% of our patients, 1 in 4, will be seen within a year in one of our emergency rooms for an SUD-related visit. 19% will be seen for something other than an SUD-related visit. So a couple of opportunities on this screen for intervention, 1 with postpartum visit attendance, and 2 for intervention to prevent emergency department need for emergency department utilization. So now flipping the lens to babies. If we've had 835 pregnancies, we have delivered 851 babies because of multiple gestations. Neonatal outcomes, the median gestational age at birth is 38 weeks. We do have a 23% preterm birth rate, a 21% NICU admission rate, a 14.8% low birth weight rate, and 1.3% fetal demise of our parent population of 851 babies. Yeah. I also wanted to say that there are other PSUDS clinics, perinatal substance use disorder clinics in South Carolina. And then in North Carolina, there is a wonderful network of PSUDS clinics called the North Carolina PSUDS Network. And you can see the 6 different clinics there. Again, a more populous state doing higher volume of deliveries, but a little bit more organized by way of linking their PSUDS clinics together. Um, I need to be winding down on time. I will, for this first part of the talk, these are really compelling data that were published in 2023 that looked at folks with opioid-related mortality in a population of people who are publicly insured by Medicaid. On the left side of the screen, what you observe over 365 days is all folks with public insurance and looking at causes of death over time and incidence of death again per 100,000. So you see the slope there for all causes of death and the percentage of all causes of death related to opioid. On the right side of the screen, the data are restricted only to people with opioid related diagnoses, so OUD. And what you see there is that the incidence of death by all cause is significantly increased for folks with OUD. And of course, the OUD, the opioid specific overdose mortality is increased, but really you see that all cause mortality is increased. And what they found was that folks who were exposed to MOUD had a significantly lower odds, 60% lower odds of death in a year after birth because of overdose related mortality, which is logical. And that brings us to the SEEDS program. So if 25% of our patients will show up in an ED within the first year, if half of our patients won't come back for a postpartum visit, if we know the highest risk of mortality is in the postpartum period, what are we doing there? So the Duke Endowment came alongside us a couple of years ago to help us stand up the SEEDS program, supportive engagement for every dimension of substance use in postpartum patients. This is a pilot program of intensive case management in the postpartum period that will follow members of the program through 3 years postpartum. This is led by Sarah Key with 3 other case managers working on her team, and each of the case managers can carry about 25 patients per load. So that ratio is significantly different than what our office staff have by way of number of patients per case manager. And we're really excited to see the data coming out of this program and very grateful to the Duke Endowment for their funding. So Magdalene is the parent program. SEEDS program is number 2. Number 3 is a dental restoration program. At year's end, we had a donor in South Carolina who reached out and said, what would you do with unrestricted funds? And we said, we know exactly what we would do. We would pay for teeth. And that may sound crazy if you're a gynecologist, but it doesn't sound crazy at all if you take care of people with substance use disorder. One of the number 1 barriers that folks have in the workforce and being gainfully employed is very poor dentition. It impacts self-esteem and it impacts the desire of a potential hiring agency to take someone on and represent their company. So with the gift of $35,000 from Samaritan Biologics, we have set up dental restoration micro grants to help cover complete restoration for patients. And here, hot off the press, is our new QR code to scan for information. More to come on that, but really excited about that. And then finally, very new, but as of last week, we met with folks at the TD Bank Philanthropy in Philadelphia who've been highly supportive of another program that we run called the Black Doula Program and said, what else could we do to be supporting your work? And we pitched the idea of helping fund a peer support doula program here in the upstate. There are existing models, I believe, in Charleston and the Midlands, but we had nothing like it in the upstate. And we're very excited about their engagement around that. So I don't want to speak too soon and get ahead of my skis, but we're really excited about the possibility of their funding in this. So hopefully more coming soon. And then finally, just a research arm taking care of this volume of patients with this specific geography and this specific kind of social constraints, it's really important to have researchers partnered with us. I am not a researcher by nature, but am delighted to partner with people on this slide. Dr. Melissa Fair was one of our earliest partners, Furman's IACH program, and she brought along multiple other investigators, Dr. Phyllis Rayner in Columbia, Dr. Heidi Zinzau at Clemson, Dr. Connie Gill on the call from Charleston. Dr. Ali Kamuro here with us in our department did some really interesting work around stigma. And then Jada Hart from our medical school is pictured in the middle in that beautiful kind of pumpkin colored blazer, who recently presented an oral presentation at the Infectious Disease Society of Obstetrics and Gynecology National Annual Meeting coming out of the Magdalen Clinic. She was really looking at our model and the impact of our model on congenital syphilis rates, which is a whole nother story nationally, the incredible prevalence of syphilis right now. And what she found is presented here. We had screened in this cohort 491 patients, 21 were confirmed positive. We were able to get adequate treatment for 14 of those 21, which means they were completely treated greater than 30 days before delivery. We were able to get complete treatment, but not necessarily within 30 days for 18 of the patients. And then we found no congenital syphilis in any of our patients with adequate treatment, but we did find evidence of presumptive syphilis in 3 infants born to patients with incomplete treatment. Our data from Magdalen were significantly improved when compared to national averages, and a source of pride and also an opportunity to do a little bit better. So I will pause. Rachel, I apologize. I am 6 minutes over into the community Q&A, but I'm going to